Thank you for joining the STSA webinar. The program will begin momentarily. Thank you for joining the STSA webinar. We will begin momentarily in about 2 minutes.
Well, first, good afternoon, everybody, and welcome to the annual Southern Thoracic Surgical Association meeting, which obviously is a virtual meeting this year. 2020 has been a year like no other, and all of us have had our lives dramatically impacted by COVID. Before we start, the leadership of the Southern offers our condolences to those who have lost loved ones because of COVID. And also before we start, we'd like to thank Beth, Rachel, and Laura and our entire Southern Thoracic team for putting this together and giving us the opportunity to spend some time together. I'd now like to introduce and acknowledge our president, Vino Thorani. Clearly, Vino will be formally introduced by Dan Miller next year before his presidential address. And I would just like to acknowledge that we have a president who's a great clinician, academician, researcher, teacher, and friend. And we're lucky to have Vino lead the Southern through these challenging times. And with that, I'll turn it over to Vino, and he will get our 2020 meeting started.
Jeff, thank you so much. And you've been incredible to work with, not only in your presidency, but also as a council chair for this year and also for potentially next year. So today, what we thought we would do in the spirit of the Southern, I know that we're so different than every other society and association that we're almost like a family. And we thought that, I know that we're not able to be together during this time period, but we thought we would share with you the top two adult cardiac, top two thoracic, and top two congenital papers that we thought were new science that we thought was just absolutely phenomenal. We thought we'd give the opportunity for those special individuals to present their data in front of all of us. So I'm so proud that we were able to put this together, and it's really the staff of the STSA that takes all the credit, and a couple of us, Joe Schmoes, were just kind of guiding them a little bit. So a couple of announcements. All moderators and speakers should remain muted with their video turned off during the pre-recorded presentations if they're not participating in an active discussion. If you're on a phone, please turn your computer speakers down. An echo is created when the phone picks up computer audio. Please be mindful of the environment while your video is enabled. We don't want you to be a Twitter account down the road or some untoward event. Attendees are encouraged to participate in the live discussion by utilizing the Q&A functionality. I think all of us know in now Zoom world how the Q&A works. We will be specifically having digital moderators who are assigned to monitor these questions. The webinar is being recorded, and you'll be able to see this at the stsa.org and CTSNet in the coming days. And then STSA CME will not be offered in conjunction with this webinar, since this is not a true meeting of the Southern Thoracic. The last thing we'll say is that the STSA members are strongly encouraged. We're going to have a virtual STSA business meeting on Saturday, December the 12th at 9 a.m. We do need to have at least 50 people on this business meeting. There's some unbelievably important stuff that we'll need to discuss. So please try to be on that. It's just going to be for 30 minutes. So we really appreciate you taking Saturday morning and having coffee with the Southern leadership. So two of the other things that I want to mention to you that we've been working on a membership drive. So we really encourage you as members of the Southern to continue to drive our membership so that we are able to extend our family even more. And we'll be coming out with a new ad hoc committee on communications, and we'll be planning on every other month or so newsletters about the members of the Southern Thoracic. So if you have any specific things you want us to cover, please email me directly. You guys know how to get in touch with me, or the Southern Thoracic. You can email them, and they'll also let you get in touch with me so we can start working on that. So without further ado, I think we'll go ahead and start off with the first pre-recorded talk. And this will be by our past president and council chair, Jeff Jacobs. And this will be experience with 100 patients with COVID-19 and severe pulmonary compromise treated with ECMO. Jeff.
It is my pleasure to present our multi-institutional analysis of 100 consecutive patients with COVID-19 and severe pulmonary compromise treated with ECMO. Our disclosures are shown on this slide. All of us have had our very existence impacted by the COVID-19 pandemic. Indeed, life as we know it has changed dramatically, stunningly, rapidly, and globally. The evolution of the treatment of patients with COVID-19 is unlike any event ever seen in medicine. As of October 24th, 2020, 42,299,535 patients around the world have been diagnosed with COVID-19, with over 1 million associated deaths, calculating to a 2.71% mortality rate worldwide. Meanwhile, in the United States of America, as of October 24th, 2020, over 8 million patients have been diagnosed with COVID-19, corresponding to over 200,000 associated deaths and a corresponding mortality rate of 2.64%. The purpose of this manuscript is to review our multi-institutional clinical experience in 100 consecutive patients with confirmed COVID-19 and severe pulmonary compromise supported with ECMO at 20 hospitals, and to document outcomes and trends in management over time. A multi-institutional database was created and utilized to assess all patients with confirmed COVID-19 who were supported with ECMO at these 20 hospitals. This database is a component of the Specialty Care Scope database. Statistical methodology is shown on this slide. This figure depicts the distribution of all 100 patients by category of outcome. 42 patients died on ECMO or within 24 hours of decannulation. 8 more patients died beyond 24 hours after decannulation but prior to hospital discharge. And 50 patients currently survive, with 49 discharged from the ECMO providing hospital and 1 still in the ECMO providing hospital. Mean and median age of all patients was 50 and 51 years respectively. 2/3 were men. Survivors were younger than non-survivors, with a median age of 47 years in survivors and 57 years in non-survivors. This graph depicts the distribution of the age of the patients, comparing the survivors with the non-survivors. Again, survivors were younger than non-survivors. 1 or more pre-COVID comorbid condition was present in 80 out of 100 patients, including obesity in 57, hypertension in 39, diabetes in 37, and asthma in 20. No difference in pre-COVID comorbid conditions were present in survivors versus non-survivors. Mean and median time from COVID diagnosis to intubation was 4.9 and 3.5 days, respectively, and mean and median time from intubation to cannulation was 4.5 and 4.0 days, respectively. No difference in these time intervals were present in survivors versus non-survivors. Mean and median time on ECMO was 16.9 and 12 days, respectively. Again, no difference in this time interval was present in survivors versus non-survivors. This figure depicts the distribution of hours on ECMO, comparing the survivors with the non-survivors. Again, no statistical difference was seen between survivors and non-survivors. Adjunctive therapies received while on ECMO were remdesivir in 34 patients, convalescent plasma in 44 patients, hydroxychloroquine in 37 patients, interleukin blockers in 45 patients, prostaglandin in 33 patients, and steroids in 54 patients. No statistical difference was seen in the use of these adjunctive medications and therapies between survivors and non-survivors. This fascinating figure depicts monthly trends over time in the utilization of these 6 adjunctive therapies in patients with COVID-19 while on ECMO during the 5 months of this analysis. The use of remdesivir, interleukin-6 blockers, and steroids increased notably, while the use of hydroxychloroquine and prostaglandin plummeted. Veno-arterial ECMO was used in only 4 patients with only 1 survivor. Meanwhile, veno-venous ECMO was used in the remaining 96 patients with 49 survivors. In conclusion, our analysis of 100 consecutive patients at 20 hospitals reveals that ECMO facilitates salvage and survival of select critically ill patients with COVID-19. Survivors tend to be younger. Survival of patients supported with only veno-venous ECMO is 51% in our cohort. Substantial variation exists in drug treatment of COVID-19, but ECMO offers a reasonable rescue strategy. Additional gathering and analysis of data will inform appropriate selection of patients and provide guidance as to the best use of ECMO in terms of timing, implementation, duration of support, and best criteria for discontinuation. Expansion of studies, such as the current analysis presented here, will provide a means to further define the role of ECMO in the management of severely compromised patients with COVID-19, and will serve to refine the optimal use of ECMO in these patients, with the goal of continuing to enhance survival. Thank you.
Great, thanks so much. Jeff, Kevin, the discussants for this will be Rania Provenza from Houston, Kevin Akela from Orlando, and myself from Atlanta. Kevin, are you on? I think he was on, but he had some connection issues. All right, so maybe I'll go ahead and, Jeff, thank you so much. That was a great presentation. I remember seeing this abstract early on. It was just very compelling, and you've built on that from the original abstract that you guys submitted. And this is one of the early papers presented in cardiac surgery from ECMO. So congratulations to you and others for putting this together. Quite honestly, they're sobering results, right, with a 50% mortality in young patients. So a question for you, maybe I'll start off while Kevin's coming on board or as Ronnie is also looking. Please, I just want to give you a reminder, please use the Q&A to be able to submit any questions that you may have for the attendees. So what is the role for eCPR, in this management of patients with COVID-19? And maybe a second kind of question that falls into that is that the patients look like they were an 8-day time period. They were intubated about 4 days and they were on ECMO for about, 4 or 5 days. One of the things that we learned early on, we've done about 45, 50 ECMOs at Piedmont Heart Institute, by the way, just in our one institution since COVID. And we realized that the patients were taking too long to get intubated or they were getting too long to be put on ECMO. And so that kind of rolls into the role of eCPR. So can you just comment about that? Were you early on doing it too slow as far as intubating people and going from intubation into ECMO?
Yeah, I think, Vino, these are both very good questions. This is obviously a multi-institutional series, and this was the first 100 patients in our series, which now is up to over 200. So these are patients who were placed on ECMO in March, April, and May. And during that time, none of the institutions involved in this study were offering eCPR. And in fact, even now, none of the institutions are offering eCPR to COVID patients. I think there's so much concern about the overall dismal outcomes in COVID patients that when they deteriorate to arresting and getting CPR, it's just something that the institutions involved in this analysis have not been offering. I guess if one had a very young patient without serious comorbidities, one could consider offering eCPR and putting a patient on ECMO during CPR. But there's a lot of complicating factors ranging from the risk the healthcare team might be at trying to cannulate a patient during CPR to the overall grim prognosis. So I think as far as eCPR goes, I would summarize by saying, I don't know of any centers that are offering that for COVID at this time, certainly none in our series. And as far as timing of getting patients onto ECMO, I think a general consensus is that the sooner the better, especially in a young salvageable patient. Although there's no solid data that I know of that shows outcomes are different in those placed on ECMO earlier rather than later. I think the feeling of most of the hospitals that are doing this is that if ECMO is going to be offered, it should be offered sooner.
Past President Kevin, Dr. Ackloff.
Yeah, Jeff, thank you for a very nice presentation. You know, there's a lot of discussion about whether veno-veno ECMO or veno arterial ECMO is necessary and which is more advantageous. What did your data show in regards to making this decision process? And to kind of follow up with Vino's question in regards to CPR, did that change any of your plans from a resuscitative effort?
Yeah, well, again, first in this series, no patients received CPR before going on, or while going on ECMO or before going on ECMO. The overwhelming majority of patients in this series, 96 out of 100, received only veno-venous ECMO, where the survival was 51%, 49 out of 96. In the veno-arterial group, there's only 4 patients with 1 survivor. I think most centers that were involved in this multi-institutional analysis were reluctant to offer veno-arterial ECMO for COVID. I think the feeling was that it's reasonable to offer veno-venous ECMO in the setting of isolated respiratory failure, but when the disease all of a sudden involves hemodynamic instability, multi-system dysfunction, and cardiac dysfunction, most centers were not offering veno-arterial ECMO. The place where it may play a role is similar to the potential role for eCPR in the setting of a younger patient without severe comorbidities. But really, the only difference we found in the survivors versus the non-survivors in this whole analysis was that the survivors were younger. So I think maybe if we had a younger patient that had not a lot of other comorbidities, veno-arterial might be a reasonable modality. But veno-venous really represents the overwhelming majority of patients in this series.
That's great. Ronnie, I know we're getting some questions. Do you want to go through some of, as a digital moderator, do you want to go through some questions that we're getting on the chat?
Yeah, absolutely. Jeff, thank you so much for this great manuscript. I mean, we have, one of the questions is, what are the winning criteria for, for ECMO, and what type of ventilation you use for patients with ECMO, and if you can comment on the size of the cannulas that you have used for the ECMO.
Yeah, so those are very good questions. In this data set, the criteria for going on ECMO and the criteria for coming off ECMO were based on the criteria and goals at any individual institution. So we didn't capture the detailed blood gas parameters associated with going on ECMO, and similarly, we didn't capture the weaning criteria. That was left up to every individual institution. So I can't really comment on that from this particular data set. I see how in the chat room there's a question that relates to utilizing a dual venous drainage cannula, such as the Protect Duo cannulation. And I think that's a really important question. Initially, in March and April, the majority of centers utilizing veno-venous ECMO were doing this with 2 separate venous cannula. And part of the reason for that was just to simplify the cannulation strategy, avoid the need for echocardiographic guidance or fluoroscopic guidance for placement of a dual venous drainage cannula. I think as people have gotten more experience with COVID, more people are now using a single venous drainage cannula, both for drainage and infusion.
Great. And then a question is that a lot of things have been said regarding the safety for the ECMO team in patients taking care for the ECMO team in patients taking care for the COVID. With COVID, and what are the strategies that we have used to, utilize to assure the safety of the ECMO team when we take care of the COVID patients?
Yeah, I think this is a very important question. And this is a question that I've had the pleasure of discussing with large groups of perfusionists. The group that maintains this database, Specialty Care, has also put on weekly webinars with the perfusionists responsible for patients on ECMO. And we've had multiple discussions with how do we make this safe? And a couple of common themes. One, obviously universal precautions, N95 masks and full protective eyewear. Cannulation takes place in negative pressure rooms. Cannulation for ECMO in this setting is not a teaching case, so the members of the team are minimized, where we try to have surgeon and assistant, a perfusionist in the room, but really nobody else. Very different from some ECMO cannulations where there might be 20 people in the room. We really minimize the number of people in the room. And then there's some strategies when the patients are on ECMO that have been utilized by different centers, which include positioning monitors and the ECMO console so that they can be viewed from the window outside the room, so that the ECMO specialist monitoring the patient doesn't have to be in the room all the time, but can view the monitors, can view the console, and do a lot of the ECMO specialist work from outside the room, minimizing direct exposure. And that's some of the lessons that I've learned from talking with perfusionists and ECMO specialists that are involved taking care of these patients.
Yeah, Jeff, we have about 2 minutes left, Jeff, before we get to the next topic. There's some, first of all, thanks to everybody for all the questions there. I wish we're going to try to keep track of this and have Jeff try to send you some answering questions to these later. But one of the questions that James Nielsen asked was the thrombotic issues. I want to bring that up, especially as a cardiac surgical field. That's important. What were there thrombotic issues and during this, and did you change your anticoagulation protocols during ECMO? I think that's a really important question, James.
That's a huge question. And although I didn't present data related to this topic, I can tell you that during these phone conferences and Zoom conferences we had with perfusionists from all over the world, this was a very commonly raised issue. And the general feeling amongst the perfusionists and ECMO specialists is that thrombotic issues are more common in ECMO patients with COVID than other types of ECMO patients. It was a theme that was discussed on multiple Zoom conferences, and our team received many phone calls about what's the optimal anticoagulation strategy for COVID patients. Why do we think that they have an increased incidence of thrombotic complications, and what can we do about that problem? And I don't think I have any good answers to all of this. Both heparin and bivalirudin have been used for anticoagulation for patients with COVID on ECMO. I think there's a trend over time to use more bival and less heparin, but I really don't have a good answer on how to prevent these dreaded thrombotic complications.
But you didn't change the ACT if you're using heparin. You didn't change that as a parameter. You just use regular ECMO parameters for that then, Jeff?
Yeah, that was the strategy that was used at most of the centers in this study. Okay. And then I think the ACT parameters and the PT-PTT parameters were modified over the course of the study in no controlled fashion, just like these medicines were changed in no controlled fashion.
All right, perfect.
And I think it's really a concern because thrombotic complications occur more frequently in these patients, but I don't have a good data-driven answer as to how to solve that problem yet. It's certainly an area that needs to be studied.
Congratulations, Jeff. That was a great study, unbelievably well presented. We're going to go ahead to the next topics. Harold, you want to take over?
Thank you, Vino.
Great. Good job.
Our next presentation is going to be a congenital paper, sequential staging of univentricular palliation within a single hospitalization. It is going to be presented by Dr. Ram Subramanian from the University of Southern California. Ram?
The President, moderators, ladies and gentlemen. We now present our results studying sequential staging of univentricular palliation within a single hospitalization. We have no relevant financial disclosures with respect to this presentation. As is well known to this audience, surgical palliation of univentricular physiology entails staged surgical procedures that eventually establish a Fontan circulation characterized by passive venous return of blood to the pulmonary circuit. Anecdotally, it appears that there is increasing prevalence of keeping infants hospitalized between the first and second stages of surgical palliation for single ventricle physiology. Such an approach may be driven by medical necessity when complex medical care may not be feasible to be delivered in a domestic situation, or a social necessity when the family situation may preclude safe discharge. In rare instances, such a practice may be driven by a specific programmatic preference. It is currently unclear if such an approach of keeping infants hospitalized is driven by a perceived increased complexity or preoperative risk prior to stage 1 palliation, and whether such an approach is necessarily associated with worse outcomes. We sought to evaluate the practice of sequential staged univentricular palliation within a single hospitalization, with an aim to describe the frequency with which this practice happens, the variability of this practice over time and across centers, and outcomes of patients that are managed by such a strategy. To that end, we queried the STS congenital heart surgery database for the time period January 2010 to June 2018, and specifically collected information on patients who fell into one of two scenarios. Scenario 1 included all patients whose primary operation was a Norwood procedure, followed during the same hospitalization by any one of the codes for superior cavopulmonary anastomosis, including, say, hemifontan or cavopulmonary anastomosis with atrioventricular valvuloplasty or pulmonary arterioplasty, etc. Scenario 2 included all patients whose primary operation was the hybrid stage 1 palliation code, such as branch PA bands, ductal stent, or a combination of both, followed again during the same hospitalization by a Norwood procedure. Preoperative characteristics and outcome data were collected and evaluated. We also calculated the proportion of patients who were managed by these kept hospitalized practice over a denominator of all patients who underwent initial Norwood or hybrid stage 1 operation within each center to assess the variability of practice across centers. The primary endpoints of the study are shown here. We studied outcomes, which included database mortality and postoperative length of stay, defined as days from index operation to database discharge. We studied the time interval between the first eligible cardiovascular operation to the second. And we also lastly studied the prevalence of preoperative risk factors as defined for the primary index operation. Standard statistical methodology was used, and here are our results. For scenario 1, 5,880 patients underwent an index Norwood operation during this time period, of whom 417 or 7.1% patients were kept in the hospital until stage 2 palliation. In scenario 2, following hybrid stage 1 in 1,132 patients, 204 or 18% patients were kept in the hospital until subsequent Norwood procedure. In both the scenarios, the numbers of patients who were kept hospitalized through to the second stage increased over the duration of the study. Roughly twofold more patients at 12.3% were kept hospitalized during the 2014 to 18 time period compared to 6.3% patients between the 2010 and 2013 time period. Despite this change, the proportion of patients managed by these staged and kept hospitalized scenarios varies widely across centers, as shown in these histograms. The histogram on the left depicts the range of patients who were kept hospitalized through stage 2 in scenario 1. As can be seen, This percentage varies from 0 to 100% with a median of about 4.1%. To the right of the screen is a histogram for scenario 2, again showing a range that goes from 0 to 100%, but this time the median is roughly around 7.1%, a slight move towards the right. This stacked bar graph shows the same data in a different fashion where each bar represents an individual center and the stacked columns in different colors shows the proportion of patients that fall into the various cohorts of management, such as diseased after stage 1, discharged alive after stage 1, and kept hospitalized through to stage 2. Again, this clearly demonstrates that in scenario 1, there is wide variability of patients who are kept hospitalized through stage 2 palliation. A similar stacked bar graph for hybrid shows the same finding of significant inter-institution variability with this practice. For both the scenarios, patients that were kept in the hospital through to the next stage of palliation had significantly higher risk factors pre-stage 1 intervention. For example, the need for preoperative mechanical circulatory support was 3.7-fold higher in patients who were kept hospitalized compared to those that were not in scenario 1, and 1.2-fold higher in patients who were kept hospitalized versus those who were not in scenario 2. Similarly, mechanical ventilation, renal dysfunction, and shock present at surgery were all more frequently seen in patients who were kept hospitalized through the subsequent stages of palliation. As would be expected, the postoperative length of stay was significantly prolonged in both scenarios in patients who were kept hospitalized through subsequent stage of palliation. Despite this, survival to hospital discharge was not lower in patients who were kept hospitalized compared to the traditional discharge strategies for either scenario. This is particularly relevant considering that these patients who were kept hospitalized had a longer at-risk time period in the hospital and underwent another subsequent surgery as well. This table shows the numerical values for the results I just presented. Again, postoperative length of stay is statistically significantly higher in both scenario 1 and scenario 2, whereas mortality is not comparably different in either scenarios. In conclusion, sequential staging of univentricular physiology during single hospitalization appears to be increasing in prevalence based on our results, although there is wide variability across centers with the utilization of such a practice. Stage 1 patients who are kept in the hospital through to the second stage palliation have a higher pre-stage 1 risk factors and therefore represent a high-risk group of patients. Despite belonging to the high-risk group, survival to hospital discharge is not lower in the patients who are kept hospitalized through second stage palliation, despite having a longer at-risk time frame and having a second stage surgery during the same hospitalization. Based on our results, future studies are required to identify what specific subset cohort of patients are likely to benefit from this strategy of sequential staging of univentricular palliation during the same hospitalization. We thank the Society and the organizers for the privilege of this floor and will take any questions at this time point. Thank you.
Ram, excellent presentation, very interesting. Can you maybe tell us why you think this is becoming more prevalent over the past, I think you had over 8-year period. It seems to have more than doubled the amount of patients doing this. Do you have any thoughts? Are they more complicated patients? Is it as easy as that, or what are your thoughts?
Thanks, Dr. Brookhart. That's a great question. with a database study like this, we're purely descriptive. So it's difficult to understand the intent for why these types of palliation was chosen. But if we were to speculate, it is possible that more and more patients are now surviving Norwood despite additional risk factors or comorbidities, and therefore there's a greater need to keep them in the hospital between stages. The second may be because we as centers are becoming better at understanding what kind of interstage care is required and what may or may not be provided in an out-of-hospital setting. So I believe that this change in how we approach the patients may, at least in part, contribute to the increase in keeping patients in-house between two stages.
Thank you very much, Ram. Before I go on, since I'm sharing the podium with Harold, I'd like to thank and acknowledge both Harold and Rania for chairing the program committee and first planning a face-to-face meeting and then planning a virtual meeting, so doing double duty in running the program committee. Thank you both very much. And Ram, I'd like to congratulate you for an excellent presentation, and I'd like to thank you for all of your tremendous leadership with the STS Congenital Heart Surgery database in general. I thought that was a very thoughtful presentation that expanded on both the strengths and the weaknesses of STS data, a topic that you know about really better than almost anybody at this point. There's a question that we have from the discussion panel from Carl Backer, and we would note first of all that Carl Backer is a past Osler Abbott Award winner from 2019, quite recently, also a past CHSS president. And Carl has asked two questions that relate not only to the study, but to the STS database in general. I'll ask them both. First, he says, is there any data comparing 1-year survival between these two groups? And second, he asks, is there any estimate of cost of keeping these patients in the hospital through stage 2?
Carl, these are both obviously excellent questions, but as you well know, the current STS congenital heart surgery database only collects data until database discharge. It does not have reliable data for 1-year survival or anything other than 1-year survival outcomes. We've started collecting 1-year outcomes in the STS database as part of the last data upgrade, but as for this study, we do not have any information on what the 1-year outcomes are, what the costs are. That doesn't mean the question is not relevant. It's extremely important. We simply don't have the data in the database to answer it.
Ram, do you have any idea on, sometimes that scenario 2 is used because the patients felt too sick to undergo a Norwood, so they may just get bands. Do you have any idea about the number of patients that just got bands with maybe they were going to get the Norwood but didn't get the Norwood?
Yeah, that's an excellent question. We don't have direct numbers on who had so-called just a band and didn't go through to Norwood. What we do know is in our scenario 2, the patients that had hybrid palliation but weren't discharged to the hospital alive, from the hospital alive after that stage. We only have that information, but we can certainly collect data on who were banded but did not ever undergo a Norwood.
Thanks, Ram. We've got 4 more minutes here, so there's a couple of quick questions I can ask from the chat room. First of all, Andy Lodge, who's another active leader in the Southern Thoracic, he asks, do you think your data suggests an advantage to the strategy that you described, or should a direct comparative study be done?
Ideally, a direct comparative study should be done because a lot of these decisions to keep the patient in-house, as we saw, vary between centers, which can only imply that they are heavily influenced by local factors such as case mix and the social situation of the patients and how they're being discharged. So the ideal way to answer this would be a center-specific comparative study to see which methodology results in better outcomes.
And thanks, Ram. We'll ask one more final question before we move on to the next paper. Dr. Polemenikos says, were the groups studied preemptively determined to undergo sequential strategy, or was this determined post-op after the first operation?
Great question, Tassos. Again, the database doesn't allow us to answer questions of intent like you're asking. That is, did we know upfront that we were going to keep this patient in-house between the two stages cannot be answered by a database study like ours. All we can say is this subset of patients was kept in-house and this subset was not. So good question, but I don't have an answer from our study.
Thank you, Ram, for a tremendous presentation, and thank you to our questioners, Tassos and Andy Lodge and Carl Backer. It's nice to see a strong congenital presentation and presence on this webinar. And with that, we'll turn it over to our third presentation. Thank you very much, everybody.
Thank you, Jeff. To continue the program, the next presentation will be by Aaron Williams, who's representing the University of Michigan, and he will be presenting similar long-term quality of life outcomes following robotic versus open transhiatal esophagectomy. Dr. Williams.
Hello and good afternoon. My name is Aaron Williams, and I'm a fifth-year general surgery resident at the University of Michigan. I'd like to thank the STSA for the opportunity to present here today. Our work highlights comparing long-term patient-reported outcomes between open and robotic transhiatal esophagectomy for esophageal cancer. We do have several disclosures, as you can see here. Esophagectomy continues to be the primary treatment modality for patients with local regional esophageal cancer. Within the last decade, minimally invasive esophagectomy, or MIE, has grown and conferred many benefits over open esophagectomy. These include decreased hospital stay, morbidity, and mortality. These benefits, however, have largely been shown for Ivor Lewis and three-hole approaches. Now, patient-reported outcomes and quality of life have also become important metrics. MIE has been shown to provide multiple benefits compared to open esophagectomy, including decreased pain and overall better functional status. Again, these benefits have largely been observed comparing open and MIE, Ivor, and three-hole approaches. Now, although comparing patient-reported outcomes has become popular, little is known regarding comparing open and MIE-THE approaches. Therefore, the aim of this study was to compare long-term patient-reported outcomes involving quality of life and fear of recurrence for patients undergoing open and robotic THE for esophageal cancer. Now, to answer this question, we included patients with pathologically or clinically confirmed stage 1, 2, and 3 esophageal cancer undergoing open or robotic THE from 2014 to 2018 at a single high-volume center. Open or robotic THE approach was based on surgeon preference, and all surgeons included had greater than 50 esophagectomies. Regardless of approach, all patients underwent esophagectomy with a CEG anastomosis, pyloromyotomy, and J-tube placement. All patients then underwent a standard postoperative pathway. Patients were then assessed prospectively using both quality of life and fear of recurrence questionnaires. The QLQC30 is a 30-item questionnaire evaluating 5 functional domains of quality of life, function scales, and symptoms, while the OES18 is an 18-item questionnaire that evaluates esophageal cancer-associated symptoms and treatment-related side effects. The fear of recurrence survey measures a patient's anxiety and depression. Questionnaires were administered at baseline as well as 1, 6, and 12 months post-operation. Scores then underwent linear transformation, with higher function scores being better and lower symptom scores being better. Summary scores were also performed. A linear effects model was then used with patients with at least one baseline and one postoperative survey. Time, baseline, demographics, characteristics, and complications were adjusted for. We also looked at secondary outcomes, including patient demographics and perioperative outcomes. In terms of our results, there were 212 patients in the open THE group compared to 97 in the robotic THE group. There was a steady decline in survey participation at each time point after surgery to about 40 to 45% up to 12 months. However, these were not significantly different between groups. Patient demographics and characteristics were also compared. There were no significant differences in age, sex, BMI, race, ASA class, preoperative comorbidities, and prior cardiothoracic surgery between groups. There were no significant differences in tumor location, pathologic staging, types of esophageal cancer, and neoadjuvant therapy between groups. As I mentioned before, the QLQC30 is a 30-item questionnaire evaluating 5 functional domains of quality of life, function scales, and symptoms. Similar to other studies, we sought to evaluate global health, physical and role functioning, and pain. We found that there were no significant differences in these metrics between groups at any time points. The remaining metrics on the QLQC30 had similar findings. There were also no significant differences in additional function scores and symptom subscores or summary scores between groups at any time point. Again, the OES-18 is an 18-item questionnaire that evaluates a patient's esophageal cancer-associated symptoms and treatment-related side effects. We found that there were no significant differences in symptom subscores, including things such as dysphagia, pain, eating, choking, and trouble with saliva or cough, or summary scores between groups at any time point. The Fear of Recurrence survey measures a patient's anxiety and depression. We found that there were also no significant differences in these subscores and summary scores between groups at any time point. In terms of perioperative outcomes, the robotic THE patients had significantly decreased length of stay and a higher number of lymph nodes harvested during surgery compared to the open THE group. There were no significant differences, however, in the incidence of any postoperative event, patient disposition, 30-day readmission, reoperation, mortality, discharge status, and need for adjuvant therapy. There was a trend towards lower rates of reoperation with the robotic THE group. At the time of discharge, however, the robotic THE group had a significantly lower number of patients prescribed opiates for pain control. In terms of specific complications, the robotic THE group had lower rates of ileus compared to the open THE group. However, there were no significant differences in cardiac or pulmonary complications, DVT, anastomotic leak, outlet obstruction, or chyle leak between groups. Although this study shows no difference in long-term patient-reported outcomes for patients undergoing robotic and open THE, it does have several limitations. The first being, this is a single-center study. We also recognize that there has been a change in minimizing opiate prescriptions and promotion of enhanced recovery protocols in recent years. We were also unable to account for surgeon-specific factors, techniques, and patient perception. Now, despite these limitations, this is the largest comparison of robotic versus open THEs comparing clinical outcomes and the only study comparing patient-reported outcomes between these two approaches. In conclusion, this study highlights that there were no clear patient-reported benefits with robotic versus open THE, which is in contrast to other types of MIE studies. However, we did observe that the robotic THE conferred many benefits in perioperative outcomes. As such, other factors such as these outcomes and surgeon experience and comfort may be more important determinants for selecting open versus robotic approaches for THE compared to patient-reported outcomes. We also recognize that a broader evaluation of patient-reported outcomes is also needed to further determine the utility of these metrics. Thank you, and I'd be happy to take any questions.
Dr. Williams, that was an outstanding presentation. And to start off the discussion will be Dr. Shanda Blackman.
I'd like to congratulate Dr. Aaron Williams and his colleagues led by Rishi Reddy at Michigan for an excellent analysis of PRO data among 2 esophagectomy techniques applied in patients who suffer from esophageal cancer. Esophagectomy patients have one of the highest morbidities, mortalities, suicide rates, unemployment rates, and impaired quality of life compared to the general population, or even compared to other cancer groups. While both the Center for Medicare and Medicaid Services and the NQF recommend routinely gathering PRO data to improve outcomes and quality improvement, collection of PRO data amongst post-esophagectomy patients is notably absent. The COVID-19 pandemic has shifted many aspects of healthcare to remote patient care delivery and telemonitoring. No one doubts we will be monitoring and exploring the utilization of PRO data to augment what we know in healthcare. Listening to the patient is one of the best new ways that we can enhance outcomes now through PRO data. Tailoring our surgery to accommodate these symptoms patients care about and improve them is a novel way that we as surgeons can improve our care in meaningful ways. Your group at Michigan has carefully evaluated patients at specific time intervals and collected data to inform comparison amongst these 2 groups. My first question for you is, why do you think you had such a steep drop off of patients over time? The percent response went down by 40% at 1 year. Do you think this was due to the fact that you were not giving them anything in exchange? You were collecting the data and keeping the responses, but the patients might not have been getting their scores back or might not have been getting any intervention based on their score back. do you think that that might have affected your low drop-off rate for PRO data? This seems to be particularly one of the weak points when it regards to PRO data collection, as a lot of different groups are starting to collect the data, but then are having trouble finding meaningful ways to share the data with the patients and have meaningful, impactful findings to correlate with clinical outcomes.
Thank you, Dr. Blackman, for that question. And again, thank you to the Southern for the opportunity to present here today. So you're totally right. We did have a drop-off rate that was about to 40 to 45% out to 12 months following surgery. And this is clearly a limitation of our study. We definitely wish this number would have been better. However, there are several PRO papers in the literature that do have similar rates up to 1 year following the study. I think our drop-off rates are due to a number of factors. These include patient death, obviously, is one factor. And then we have a lot of patients that come from out of state, and we have a pretty wide catchment area that also affects difficulty with completing these surveys. In terms of how we did these surveys, we had our nurse research specialists attempt to complete these surveys at 1, 6, and 12 months post-surgery. And we tended to do this in the office with a paper survey. If patients did not fill out or were not able to come to the appointment, we did have the nurses attempt to mail surveys and reach out to patients that way. And so obviously, that certainly could have affected these patients. I think moving forward, we're definitely planning on using technology to help better improve these survey completion rates, whether this is over the phone or using an online survey or using a patient portal. And as you mentioned, even incentivizing could be a way to improve completion rates, although it obviously has its own limitations and bias. And then I totally agree with you on your last comment with regards to how do we feed this back to patients. I totally think that can play a role in patients not completing surveys. And I think this is great information. This data is great information for us to have as clinicians and surgeons. But we definitely need to feed this back to the patients to help inform clinical decision-making and surgical selection. And I think overall, this is very important data for patients to know.
My second question is, the leak rates were quite discrepant between the two groups, 15% in the transhiatal group and 9% in the robotic group. I'd like to congratulate you for such great outcomes with regards to your robotic dissection and the lower leak rate. So do you think that you were underpowered to show a difference between those two groups, and maybe there is some meaningful difference if you had more patients enrolled? What are your thoughts on that, and what do your surgeons think about that?
Yeah, that's a great question as well, Dr. Blackman. So you're right, the robotic THE group had a lower leak rate at 9% compared to 15% in our open THE group. Again, the primary outcome of the survey was looking at patient-reported outcomes for patients who complete at least one baseline survey and at least one postoperative survey. So there were a number of other patients that also underwent a THE during this time period that were not included in this cohort of patients just because they didn't complete the surveys. I definitely think that there could be an underpowering of the analysis that definitely could have showed this to be significant should we have more patients. We're trying to look overall at our data in the last 8 years since we've been doing robotic THE and open as well to look at kind of a full analysis of these patient outcomes and hopefully to want to have that soon for everyone to see here in the next year or so.
So I knew this was coming. Dr. Steve Yang, who is a legend within the Southern Thoracic, has congratulated you on your study. He thought it was beautifully presented, but he wants to know if you predict that open transhiatal esophagectomy will become obsolete. And what would Dr. Oringer say? What are the indications at University of Michigan now for open THE based on these results?
Yeah, that's a great question, Dr. Yang. Appreciate that. Obviously, we all have reverence and honor for Dr. Oringer and his open THE approach. And I think that he appreciates the evolution of how things are going with surgery. I think the robot only complements things. And as we showed in our study that patients had decreased length of stay, higher lymph nodes harvested, as well as decreased ileus rates. I think right now that the open THE will probably always still have a role for patients that have significant abdominal surgeries and histories where dissections may be difficult and such. But we are starting to look at who best would benefit from the robotic approach compared to open. And I think patient selection and studying that a little bit more over the next upcoming years will be really important. I'll say hello to Dr. Oringer for you as well.
How do you manage that in your group? If patients come into University of Michigan, are they asked if they want a robotic or an open approach? Are they offered that when they come in through the front door and then shuttled accordingly? Or do they get what they get when they get referred to their surgeon of choice?
Yeah, so we have in our group right now, we have 6 that perform open THE and 2 that do robotic THE. As far as the way this went in our study, the robotic approach was based on the patient being open to it and robot console availability. And so I imagine as we get another robot and this, our data shows promising, we'll probably continue to use the robotic approach. I think there will always be a role for the open approach based off patient selection. And we have in fact already started to give this data back to patients showing benefits with the perioperative outcomes with our early studies and highlighting and conveying these patient reported outcomes as well. So we have definitely more work to do and more things to study. We look forward to doing that here in the next number of years.
Aaron, that was a great job. I just have 2 quick questions. It was interesting that the reoperation rate was almost twice as much for the open THE. I don't know if you could expand on that. Was that the reason that the hospital stay was longer?
I certainly think so. I think, the robotic approach, I think is there's been increasing adoption of that over the years. Provides awesome visualization for short gastrics up near, the spleen and looking at the stomach a little bit more. And I wonder if we can better preserve the blood supply in the area that we're anastomosing, and that certainly can contribute. I do think the robot approach also offers pretty amazing visualization for performing the hiatal dissection, and actually we can get pretty high to the level of the carina, if not higher, with the lymph node dissection. And I think being able to do that under direct visualization with a robot, also, I didn't show this data here, but also the robotic group had decreased blood loss compared to the open THE group as well too. And so some of the reoperation was due to leak, some of it was due to bleeding and such. And I think at least our early data here, again, this was, these were the secondary outcomes of our study, but they do appear promising. And I think the robot is definitely being very, very beneficial in these cases.
Yeah. And I
so
think
as a resident, do you think it's easier to do the open first and then the robotic? So you get your bearings?
Yeah, I love open surgery personally, so it will always have a place in my heart for it. But I think it is. It's awesome to see the anatomy, the lay of the land, and how to do this case, and then it definitely sets up things nicely for once you get a feel for the operation and doing it robotically. And I think they're both great approaches.
And just one other thing about blood loss is you happen to go back and look at surgeon glove size. I think a lot of times on some of these patients, through a transhiatal, it can be a little aggressive, manipulation of the esophagus up through there, and the robot may take away that bleeding issue from the, asgus vein branches or, peri-aortic vessels coming off. That's just kind of a funny comment. But the last one was that if you looked at, I think robotic is the way to approach. When these patients were discharged from the hospital, almost twice as many was sent to a rehab center or to a nursing home compared to the open technique. And I thought that was very surprising.
Yeah, both great comments. We did not look at the glove size, but obviously that does play a role in the approach and getting, in the mediastinum and up that way. And then again, that's also a great question as well. There is a doubling in terms of the discharge, dispo status. Again, I think the study was probably truly underpowered to look at full differences. I do think that's an interesting point. I think in the future, we need to obviously get a larger cohort and even start performing multi-institutional studies to get a better lay of the land for comparing perioperative outcomes between the approaches.
And there was one other question that came across from Dr. Nielsen. I wanted to know about the number of robotic cases that were done by the surgeons. Was there a learning curve that occurred during this time period?
Yes, that's a great question as well. Prior to the start of prospectively enrolling patients in this study, all surgeons had completed at least 50 esophagectomies, including the robotic cohort. So we do feel like the staff faculty were well beyond their learning curve for this operation for the study.
I think we have time for one last question. Mark Block was asking if any of your surgeons do a laparoscopic approach, or is it one or the other, either open, transhiatal, or robotic?
Yeah, that's a great question, Dr. Block. We do have a number of surgeons that do a laparoscopic approach for the just making the data homogeneous. We chose to just include robotic, but we do have a number of staff that do laparoscopic. I do think that the robot has the advantage over laparoscopy in terms of able to get up into the hiatus and the mediastinum. And I think with the robot, you can do a much higher dissection, again, to the level of the carina, if not higher with the robot. And I think that's just something that is a little tougher to pull off laparoscopically. And so I think, that approach, the robotic approach, can contribute to decreased blood loss and better lymph node harvesting. Again, I haven't compared the robotic to the laparoscopic data, but I think, if one of the criticisms of THE is the oncologic resection, I think the robot can definitely help visualize that and get a much better radial margin and even have less blood loss.
Congratulations, Aaron. Nice job fielding questions.
Excellent job. Let's go on to the next presentation.
So we're going to continue the webinar with the second adult cardiac surgery paper. And before that, we would like actually to thank all the past presents of the Southern who participating in the dialogue and the chat. So the second adult cardiac surgery paper is from Dr. Mehaffey and colleagues from University of Virginia regarding the aortic annular enlargement, short and long-term outcomes in the United States. Dr. Mehaffey.
Hello, and thank you for the opportunity to present our work entitled Aortic Annular Enlargement, Short and Long-Term Outcomes in the United States, on behalf of myself and my co-authors. Patient prosthesis mismatch is associated with significant long-term morbidity and mortality after aortic valve replacement, and has garnered significant interest with the rise in transcatheter aortic valve replacement and valve-in-valve TAVR. However, indications and outcomes of annular enlargement in order to allow for a larger prosthesis remain poorly defined. The purpose of this study was to describe the safety and current practice patterns around the use of annular enlargement across the national STS database. We hypothesized that increasing rates of annular enlargement may lead to improved outcomes for patients at risk for severe patient prosthesis mismatch. We began by querying the STS National Adult Cardiac Surgery Database and identified over 600,000 patients undergoing aortic valve replacement with or without concomitant coronary artery bypass grafting between 2008 and 2016. After excluding patients who underwent emergent operations for endocarditis, patients on mechanical support, or those undergoing other concomitant procedures, we had just under 400,000 patients undergoing aortic valve replacement. These patients were then matched with Medicare-linked data to obtain long-term follow-up and survival data. Our final population was 189,268 Medicare-linked aortic valve replacement patients with or without concomitant CABG. Patient prosthesis mismatch was defined by calculated effective orifice area index based on patient body surface area and manufacturer effective orifice area, with an EOAI of less than 0.65 defining severe patient prosthesis mismatch. Patients were stratified by annular enlargement for univariate, multivariate, and time to event analysis to evaluate early and late outcomes. We looked at the yearly trend in use of annular enlargement over the study period and see here that there's no significant change between 2008 and 2016. When we assess baseline characteristics and operative risks, we see patients undergoing annular enlargement were significantly younger and had lower rates of preoperative comorbidities. However, there was no significant difference in the predicted risk of mortality based on STS risk scores. However, when we compare patients undergoing annular enlargement to those who did not undergo annular enlargement but were at risk for moderate or severe patient prosthesis mismatch, we again see the patients were younger. However, the preoperative comorbidities were significantly worse in the patients with moderate and severe patient prosthesis mismatch, and the STS predicted risk of mortality was significantly higher. When we assess short-term outcomes, we see that operative mortality, major morbidity, and the composite major morbidity or mortality were significantly associated with annular enlargement in unadjusted models. This was again true after STS risk adjustment, with an odds ratio of 1.55 for operative mortality. However, there was no statistical association between annular enlargement and postoperative pacemaker placement in this cohort. Next, we assess non-fatal long-term outcomes, and we see here that hospitalization for stroke, hospitalization for heart failure, and aortic valve reoperation were not significantly associated with annular enlargement in unadjusted or risk-adjusted models. When we assess long-term survival using landmark analysis, we see over the first 3 years, annular enlargement was associated with significantly higher risk of mortality. However, after the first 3 years, this was associated with a significantly lower risk of mortality in unadjusted models. After risk adjustment with the STS risk score, we see again higher risk over the first 3 years with no association between annular enlargement and survival after 3 years. This figure demonstrates the survival curves and how they cross at approximately 3 years, with annular enlargement group illustrated in blue. There are important limitations to this study, including the STS database does not capture the specific annular enlargement technique performed. The study was limited to patients over the age of 65 on Medicare in order to obtain long-term data on readmissions and survival. However, this may not be representative of outcomes in all patients undergoing annular enlargement. Finally, patient prosthesis mismatch calculations were based on valve size used and patient body surface area, which does not readily identify patients who were spared from moderate or severe patient prosthesis mismatch with an annular enlargement. In conclusion, we illustrate no change in national trends of annular enlargement through the rise of TAVR and valve-in-valve TAVR. We demonstrate an increased short-term morbidity and mortality in the Medicare population undergoing annular enlargement. And we established no association between annular enlargement and long-term reoperation, readmission for heart failure, or stroke, regardless of projected patient prosthesis mismatch. Finally, we highlight that survival curves cross after 3 years, suggesting a potential long-term benefit with annular enlargement in selected patients. So in closing, annular enlargement is still only done in the minority of patients over the age of 65 who are at risk for patient prosthesis mismatch. Increased early risk with no clear long-term benefit was seen in this Medicare population. However, annular enlargement may be considered in patients with predicted moderate to severe patient prosthesis mismatch in whom a long-term survival benefit may outweigh the early risk. Thank you, and I'd be happy to take any questions at this time.
Dr. Mahaffey, thank you so much for this important paper. And we're going to start our discussion with the past president of the Southern Thoracic Association, Dr. Kevin Akola. Kevin?
Yes, thank you. Arania, can you hear me?
Yep.
Yes.
Yes, sorry, I don't think the video is working. This is an important study because as we're entering this era of valve-in-valve surgery as a secondary strategy as these patients age, I think it's important to have this in our strategy in patients where we're placing smaller valves. I guess the question I have is one, Hunter, and that was an excellent presentation, is what are your certainties that these were true annular enlargements versus root augmentations? If you could answer that, and then I have a follow-up question.
Yeah, certainly. Thank you for the question. Obviously we're limited by the STS database and how these are coded. We actually recently looked at this within our own institution and within the Virginia Collaborative, and we're able to do some chart review and found that, at least at our institution, the patients who were documented and recorded as having annular enlargement, the accuracy was greater than 99% over the 20 years at our institution. So obviously I can't speak to that for the national data, but that is certainly a limitation. We don't have the specifics of what type of annular enlargement was performed. So that's the limitation of the study.
Okay, that's often difficult because of a lack of good documentation. I appreciate that. And the purpose of annular enlargement, as you stated during AVR, is to allow a larger prosthesis to prevent patient prosthetic mismatch, which obviously, as we all know, has been detrimental to long-term effects in regards to heart failure, reduced survival, need for reoperation, et cetera. But why does the present data not demonstrate some of these long-term benefits for patients undergoing annular enlargement with the curves crossing after 3 years? What's your thoughts on that?
Yeah, no, I think that's a really important question. And this study, I have to also thank my co-authors, a sort of multi-institutional collaborative here that participated in the design of this study, because it's really a very difficult question to answer. We felt like the long-term outcomes, the readmission, the reoperation were going to be very important outcomes to have for this population. So we elected to use the combined or the merged STS Medicare data, which limited us to a population over the age of 65. 65 doesn't sound that old when you're thinking about it, but the actual median age of our population was 75. So the patients that we were looking at were certainly much more advanced in age, and perhaps the early risk associated with the annular enlargement, so the juice wasn't worth the squeeze, if that makes sense. But they didn't live long enough to see the long-term benefits of the annular enlargement. I think the other important consideration here is the patient prosthesis mismatch was based on, our categorization of that was based on projected numbers based on the body surface area and what valve was used. So there's clearly limitations of the valve charts and the cutoffs for these indexed effective orifice areas. So perhaps we weren't accurately portraying what the patient's true annular size was.
Okay, well, thank you, Hunter. And yeah, thank you very much. And I think there's a lot of members on this call that probably also do not think 65 years of age is that old. But thank you. Excellent presentation. And thanks for contributing to the STSA webinar. Thank you.
James, thank you. That was excellent presentation. As Kevin mentioned before, I mean, these surgical techniques really for annular enlargement have been around for a long time. I mean, since maybe 1970s. But definitely the last decade, there is a renewed interest in these procedures. So I noticed as in your presentation that the rate of the annular enlargement was 2 to 3% during your study period. So my question is, were the authors surprised by this finding? And then why do you think the rate was so low if 2/3 of the population had moderate to severe patient prosthesis mismatch?
Certainly, that's an important question, and we were surprised. Especially we really expected, even if it was a lower rate nationally, we did expect to see a growth in the use of annular enlargement over the rise of valve and valve TAVR as people were thinking about okay, going to put a bioprosthetic valve in a younger patient, try to set them up for a future valve-in-valve, make sure that's going to be large enough. But that really was not borne out in the data, up through 2017. And that was very surprising. It's kind of one of our primary take-home messages, I think. And then the other side of that is it certainly adds complexity to the operation. There's no doubt it adds bypass time. There's an increase in blood transfusion, and the risk of increased STS major morbidities is real. The increased renal failure, prolonged ventilation. So I think all of this it's a balancing act. So it is surprising, but it's important to know what the national practice patterns are.
Yeah, great. And I would like to ask you also, but as well as, our current president, Dr. Thurani, do you think like a better study that can be performed?
Yeah, I mean, I'm a co-author for this. I'll pull a Dan Miller and make a comment on a paper that's already mine. Yeah, Dan, I hope you're still listening. So, no, I think that this troubles me in some ways a little bit, because I feel like we're going backwards a little bit in time. As here we are, the surgeons struggling with TAVR and surgery, and TAVRs have a better EOA than surgery does. And then for the first time in the Partner 3 study, we showed that surgery did a better job than TAVR did for gradients, because we did a lot more aggressive root enlargements and things like that. Mike Mack and I've talked a lot about that. So, I don't know the right answer, Ronnie. That's a good question, but I'm a little worried that the message shouldn't be stop doing root enlargements in patients. I think that's a very bad message to send to surgeons. It's not okay to put a 19 valve in somebody that's my size or Hunter's size. Don't do that. I mean, I think we have to be careful in how we do it. I mean, clearly we have to think about other roles. I was going to kind of throw it back to Hunter. One of the questions for you is sutureless prosthetic valves. Is that something to prevent having PPM?
Certainly, I think some of this comes back to the validity of the valve charts, and how well we believe the cutoff for indexed effective orifice area. There's no doubt those valves do have better performance numbers, but I think ultimately the question would be best answered by doing a study where we can match patients based on their actual annular size preoperatively, and then follow them out over a longer period of time. And again, it would need to be in an all claims database or something that would include younger patients who, in I think most people's opinion, stand to have the most benefit of an annular enlargement to set them up for the future.
Yeah, the last thing, I think we have maybe about 20 seconds left, just to ask you a question, and I really agree with this from Andy Lodge, who says, this is an older patients. Could the study be done in younger patients? And that's the one thing I would have looked at. With the National Death Index, we could do that potentially. What are your thoughts about that, Hunter, real quick?
Yeah, absolutely. I think that would be that'd be fantastic. As that new data is available within STS, certainly look at the mortality. That obviously doesn't tell the whole story. That's the thing I loved about the Medicare data, is that we got the readmissions, we got the reoperation.
That's perfect. Well, I think, Hunter, that was absolutely great presenting and the questions afterwards. So I think, and now we're going to go to Jeff.
Well, thank you, Vino, and Hunter. Again, congratulations for a fantastic presentation using STS data linked to Medicare data. Very well presented and very thoughtful analysis. The fifth of the 6 presentations today is going to be given by Dr. Bill Novick, and it really gives me a great honor to introduce Dr. Novick. He's really one of the heroes of the Southern Thoracic. This guy travels all around the world, operating in remote destinations and saving the lives of children. And he recently just got back from a trip last month where Dr. Novick and his team operated on 40 children in Iraq. He's back in town to make this presentation and another presentation at the ACC. And then after that, he's off to Libya to operate on more children there. So he's a real hero, done wonderful work, and we're very proud to have him as a member of the Southern. He's going to give a talk now that's entitled Late Results Following Closure of Ventricular Septal Defects with Elevated Pulmonary Vascular Resistance and Pulmonary Hypertension using the flap double valve technique. Dr. Novick.
I'd like to thank the program committee of the association for providing us with the opportunity to present our study of the early and late results following closure of ventricular septal defects in patients with elevated pulmonary vascular resistance and pulmonary hypertension utilizing the flap valve double patch technique. We have no disclosures to make. In upper income countries, large VSDs are closed in infancy before the development of pulmonary hypertension and elevated pulmonary vascular resistance. In low and middle income countries, the delay in diagnosis and treatment results in children presenting at an older age for VSD closure, having already established pulmonary hypertension and elevated resistance. Mortality risk in low and middle income countries is high for these patients, as these countries are without expensive medications for pulmonary hypertension treatment or ECMO rescue. We developed a unidirectional flow VSD closure patch to decrease the mortality risk. This is a single institutional retrospective study between May of 1996 and April of 2016. All patients presenting for VSD closure with PAH underwent cardiac catheterization with 100% oxygen provocation following baseline studies. Beginning in April of 2005, all patients presenting with VSD and PAH were started on sildenafil at 3 milligrams per kilogram per day for 2 to 3 months prior to cardiac catheterization. All patients who did not drop their PVR to normal with provocation received the unidirectional VSD closure patch. All patients received a pulmonary artery pressure line before leaving the operating room. An echocardiographic assessment of systolic PA pressure was obtained daily on discharge and at all follow-up visits. Analysis of the early and long-term results compared the sildenafil to the non-sildenafil groups. A total of 40 patients underwent double patch closure and are the subject of this study. Now here you can see the patient demographics and baseline hemodynamics. And as you can see, there's basically no difference between the demographics of the patients. Baseline hemodynamics, though, you do see differences in the systolic pulmonary artery pressure, the PA to systemic pressure ratio, the QPQS, the percentage of patients with a QPQS of less than 1.5, the absolute oxygen saturation, and the percentage of patients with oxygen saturation of less than 90%. All of these were much higher in the non-sildenafil group. Now, with oxygen provocation, only one thing changed between the two groups, and that was the QPQS. It rose to 3.16 in the sildenafil group and 1.70 in the non-sildenafil group. ICU and discharge data is seen here. The only thing that was really significantly different was mechanical ventilation time, which was significantly less in the sildenafil group. Inotropic score approached significance lower in the sildenafil group, but did not achieve significance. Hospital discharge mortality was 2.5%. Now, we looked at the pulmonary to systemic pressure ratios over time as a function of the median. And here you can see that there was a decrease, as you would expect, in pressure as the patients went through the system and had their VSD closed. Upon discharge, the mean pulmonary to systemic pressure ratios increased slightly, and there was a slight decrease at final follow-up. There was a significant difference between the lowest value, which was in the ICU, and the follow-up and discharge PA pressures. The degree of pulmonary hypertension at last follow-up, 21% with no, 40% with mild, 21% with moderate, and 18% with severe pulmonary hypertension. And as you can see from the Kaplan-Meier curve here, freedom from severe PAH was over 80% for both groups at 15 years and was actually 79.5% at 21 years for the non-sildenafil group. Freedom from death after discharge is seen here, and as you can see, there was excellent survival following discharge. As I mentioned, there was only one late death, and so we had a 97.3% overall survival at 15 years. Limitations of the study, it was retrospective, it was a single institution, it was a small sample size, and there was less time for follow-up in the sildenafil group. However, we believe the inferences are sildenafil pretreatment improves baseline catheterization hemodynamics and post-provocation QPQS compared to no pretreatment, thereby improving preoperative hemodynamics. Patients with sildenafil are extubated earlier postoperatively, facilitating postoperative management. Long-term survival is excellent in this cohort. Late severe pulmonary hypertension is less than 20%, and double patch operations in patients with severe PAH and elevated pulmonary vascular resistance can be carried out with low early and late mortality. Thank you very much for your attention.
Well, thank you very much, Dr. Novick, for a thoughtful, provocative presentation, and also for all the great work that you do. I will start the discussion, and then after that, my co-moderator Harold will also be able to bring some questions from the chat room. I'd like to ask you, why not simply create a fenestration within the middle of the VSD patch and then let the cardiologist close it later with a device? Why instead utilize the approach that you've so nicely described?
Well, thanks for the question, Jeff. You know, you have to look at the economics in low and middle income countries. And to give you an idea, the cost of a VSD closure device in a low and middle income country frequently exceeds the cost of the entire operation performed primarily. That's number one. Number two, if you leave the hole, you're still getting left to right shunting occurring in these patients. And although the pressure difference is significant, you still have an excess flow through the pulmonary bed and are still contributing to damage to the pulmonary vascular bed. So our preference is to put the flap valve in and allow these patients to close it on their own as their LV pressures increase.
Is that the same approach you'd use in the United States if there was the resources available for a device?
You know, the politically correct answer is yes, but the surgeon answer is, why subject these kids to having to go back to the cath lab when you can take care of it in the operating room the first time around? So, you know, that's sort of a double-edged question.
Yeah, nice answer too.
We have a few questions from the attendees. I enjoyed it very much, Dr. Novick. I've used this technique based on one of your earlier publications where you had drawings on how to do this patch. Some of the attendees wanted to know if you could describe in a nutshell how you make the patch, and then also, is there anticoagulation involved with this?
So let me answer the second question first, because we don't use any anticoagulation on these children. This is a very small part of the total group that we've operated on. We've actually done more than 250 kids around the world, and we have yet to use even aspirin on these children. Regarding the patch, what we do is, Harold, we go ahead and create the VSD patch based upon our analysis of the VSD when we open the right atrium and look across the valve. And then once you get the patch tailored, what we use is a 1/2 of the Z value for the aortic valve for that particular child as the size of the fenestration. Once that's made on the LV side, over approximately 33% of the circumference, you attach the patch so that it can act, you know, as a flap valve. And to prevent the valve from flapping all the way over, should you get really bad pulmonary hypertension, we put a tethering stitch in at the apex at the bottom, which is equal to the same size as the fenestration. We put a Hagar through, let's say the fenestration is a 6, for example. Put a 6 Hagar through and tie the tethering stitch over that so that it can only open to that extent.
And what, do you have follow-up on what happens to most of these? Are most of them closed at follow-up?
Yes. Now, let me say this, that in the cold extremes, so the kids that we've operated on in Belarus and in northern Ukraine and in northern Russia, some of those children have kept their flap valves open for as long as 4 or 5 years post-operatively. And we have a group of kids that we operated on in Colombia, and those children there, because of the high altitude in Bogota, when they go to visit the beach, they turn pink. When they're in Bogota, they're blue.
All right. So, and then I assume that you're going to be treating all these patients that you can now with sildenafil preoperatively. And when do you stop that?
So the criteria that we use postoperatively is this: the pulmonary to systemic pressure ratio is less than 0.4, then we'll actually take the patients off their sildenafil. So we look at them in the ICU before the catheter is removed, make the decision then at the discharge echo, they get a decision made then. And then at every follow-up, we're evaluating that for potentially stopping their sildenafil.
Well, I think, thank you for a great presentation and also a very nice discussion where we covered a lot of important issues. And thank you again for all the great work that you do, and safe travels to Libya, which I know is the next trip coming up shortly.
It is. Thank you very much, Jeff. Very nice introduction. I'm not sure I was worthy of it, but it was certainly nice.
You are, and we all know it. And there was a lot of nice comments about you in the chat box while you were making the presentation as well. You should know that as well. And with that, we'll move on to our final presentation of the day, and I'll turn it over to our colleagues from thoracic surgery. Thank you, everybody.
Thank you. Our next speaker will be Dr. Sean Whiteman. He is accompanied by his colleagues from USC, led by Dr. Tony Kim. And he'll be talking about adjuvant chemotherapy for visceral pleural invasion in 3 to 4 centimeter non-small cell lung cancer and how it's associated with improved survival. Thank you, Dr. Whiteman and your team.
I would like to thank the Southern Thoracic Surgical Association for the opportunity to present our abstract titled Adjuvant Chemotherapy for Visceral Pleural Invasion in 3 to 4 centimeter non-small cell lung cancer, Improved Survival. I have no disclosures. Current American Joint Committee on Cancer guidelines stage tumors 3 to 4 centimeters in size to the T stage of T2A. Similarly, smaller tumors with any visceral pleural invasion are also staged T2A. This means that smaller tumors who would by size receive a T1A through T1C classification are upstaged to T2A, given the same T2A designation as a larger tumor. Pleural invasion is classified into 3 groups. The involvement of the visceral pleura in the PL1 and PL2 groups causes the upstaging of tumors less than 3 centimeters to the T2A designation. Current National Comprehensive Cancer Network guidelines recommend chemotherapy for tumors with high-risk features in T2A N0 stage 1B patients. These high-risk features include visceral pleural invasion. But current guidelines do not break down these recommendations based on tumor size, simply the presence or absence of visceral pleural invasion. We hypothesized that adjuvant chemotherapy in these stage 1 patients who would normally not receive it due to the size less than 4 centimeters and node negative status would significantly improve 5-year survival if visceral pleural invasion was noted. The National Cancer Database was queried from 2010 to 2016 for cases of non-small cell lung cancer with clinical stage 1 disease that were less than 4 centimeters, node negative, who subsequently underwent surgical resection. These stage 1 non-small cell lung cancers were stratified according to clinical tumor sizes. This cohort was then divided into groups with and without visceral pleural invasion and further divided based upon the administration of adjuvant chemotherapy. This then resulted in 16 separate subgroups based on size: the presence or absence of visceral pleural invasion and presence or absence of adjuvant chemotherapy. Kaplan-Meier analysis was used to calculate 5-year overall survival for patients categorized by tumor size, visceral pleural invasion status, and receipt of adjuvant chemotherapy. Multivariable Cox regression, adjusting for tumor size and visceral pleural invasion status, was used to determine associations between use of adjuvant chemotherapy and overall survival. A total of approximately 61,000 patients met our inclusion criteria, 51,000 without visceral pleural invasion and 10,000 with visceral pleural invasion. As expected, when all tumors less than 4 centimeters were grouped together, survival was worse if visceral pleural invasion was present, 66.2% compared to 59.2%. In general, survival was worse when visceral pleural invasion was present. When tumors were grouped by size, as well as visceral pleural invasion involvement, overall survival for each of the separate 4 staged-based size groups was significantly worse if visceral pleural invasion was discovered, ranging from 5 to 8% survival difference for each tumor size group. When visceral pleural invasion was selected and all tumor sizes were grouped, the addition of adjuvant chemotherapy improved 5-year survival by almost 7%. When looking at tumors with visceral pleural invasion grouped by tumor size, only tumors 3 to 4 centimeters had a statistically significant increase in 5-year overall survival for patients receiving adjuvant chemotherapy, 68.8% compared to 50%. On multivariable Cox regression, adjuvant chemotherapy for 3 to 4 centimeter tumors with visceral pleural invasion was similarly associated with significantly longer 5-year overall survival. The limitations to this study are the limitations attributed to the National Cancer Database, including its retrospective nature, as well as lacking cancer-specific mortality. For this project specifically, the database lacks granularity regarding the different degrees of visceral pleural invasion. An additional limitation is the lack of clinical patient-specific knowledge on why adjuvant chemotherapy was selected for some stage 1 patients and not others. In conclusion, visceral pleural invasion remains a poor prognostic factor in clinically node-negative 4 centimeter or less stage 1 non-small cell lung cancer patients. Guidelines recommend adjuvant chemotherapy for high-risk T2A-N0 patients, including those patients with visceral pleural invasion. Based on the analysis demonstrated here, our hypothesis is specifically supported for tumors 3 to 4 centimeters in size. Adjuvant chemotherapy should indeed be considered for patients with tumors 3 to 4 centimeters in size and visceral pleural invasion due to an observed 5-year overall survival advantage. I would again like to thank the Southern Thoracic Surgical Association for this opportunity, and I am happy to take any questions.
Sean, that was an outstanding presentation. And I'd like to ask you 3 short questions. The first one is, as you stated in your limitations, that you don't know why they received chemotherapy, but were you able to look back at the institution that they received their treatment, such as an academic institution? Also, was there any relationship in regards to the payer's insurance?
Thank you. Thanks for that question. And thank you also for the opportunity. We can't determine why the patients were given adjuvant chemotherapy from the database. And that, as you mentioned, was something we identified as a limitation. Only half of the patients receiving chemotherapy had visceral pleural invasion. So they received it for some other identifying factor. But But this is the exact reason why we wanted to look at this project, because tumors less than 4 centimeters aren't classically given adjuvant chemotherapy. And we wanted to determine if patients with visceral pleural invasion were receiving it, and was there a benefit. But in terms of whether there's variations in the type of institution and whether there's variation in insurance payer, that's an excellent question, and one that I'm actually very curious about. Institution type and insurance payers, they weren't specifically identified and separated in our analysis down to the level of tumor size, visceral pleural invasion, and adjuvant chemotherapy. But that said, when we did look at our Cox regression for tumors with visceral pleural invasion, the institution type and insurance payer, they were not associated with any increase in or with any survival difference.
Okay. Second question, was there any difference in regards to the survival in those patients in regards to the type of resection, especially looking at patients who had a formal lobectomy versus a limited resection, such as a wedge resection?
Yeah, there was. Wedge resection came up as a poor prognostic factor for overall survival. And I think what we're seeing there is just the findings that support that, some of our current data that wedge resections aren't great cancer operations. And that was demonstrated through all of our tumor cohorts for these smaller size tumors.
Okay. And finally, just looking at more histopathologic characteristics, were y'all able to look at lymphovascular invasion or perineuronal invasion to kind of, put that with the visceral pleural invasion to see if that made a difference?
Yeah, we could look at those factors, and maybe we should, but we didn't in this study. We didn't specifically focus it to answer those questions. I think there's something there. Maybe there's going to be some type of melting pot or a future scoring system that we can use for some of these smaller size tumors based on multiples of risk factors that we can use to then create an assessment tool on whether patients should receive adjuvant chemotherapy.
And currently now at USC, what is your protocol for these patients now? Are they receiving adjuvant therapy, or is it depending on their biomarkers or immunotherapy, or where are you going from here?
Yeah, so for the smaller tumors in the cohort, those 2-3 centimeters in size, we're not currently giving or offering adjuvant chemotherapy unless they have other risk factors that are giving them a higher risk profile in our mind. But for some of the larger tumors, we do consider it a little bit more highly, especially considering the study that we've been working through over the past few months.
Okay. Shanda?
Sean, I congratulate you on an excellent paper and an excellent presentation. I just have a few comments. While the definition of visceral pleural invasion is clear, according to the AJCC, I would say that not everyone is aware of it. And there's a lot of heterogeneity in how it's interpreted amongst pathologists, especially in the NCDB. For instance, even in the introduction of your paper, when I read the manuscript, you state that PL1 is not beyond the elastic layer in the visceral pleura. PL2 is visceral pleural invasion beyond the elastic layer, and PL3 is invasion into the parietal pleura. That's really not true. PL1 and any visceral pleural invasion for that matter means the tumor breached the external elastic lamina of the visceral pleura. As the visceral pleura has 2 elastic laminas, that sometimes leads to confusion, and it has to be the outer external layer, not the internal layer. So any study that like this might require a re-review of that aspect by an expert thoracic pathologist to prevent the pathology interpretation from being confusing, especially when you're drawing such landmark conclusions like you are in your paper. Although that might not be feasible, we do encourage that you add this to your manuscript. The other issue I see sometimes is that visceral pleural invasion is missed as the elastic layer is pulled down by the tumor. And this you can only really identify if you do an elastic stain. So if you do toluidine blue on the frozen section, you can sometimes see that. So I would recommend that you include this addition to and this detail into your manuscript as a limitation. So I do have one additional question other than my comment. So why was the visceral pleural invasion assessment limited to tumors less than 4 centimeters in size?
Yeah, thank you. And I really do appreciate your comment. I think that those definitions for the pleural invasion are important, especially when we're making evaluation and patient decisions based on that. But in terms of the size limitation, we decided to limit the tumors to less than 4 centimeters to try to eliminate any other confounding factors on why patients would receive adjuvant chemotherapy for other reasons. We really wanted to be able to focus on visceral pleural invasion and its association with adjuvant chemotherapy.
Were you able to differentiate the difference between PDL1 and PL as it relates to the pleural invasion?
So we were able to group PL1 and PL2 together, and we were able to use those to determine whether the visceral pleural invasion was there as a definition, but we were not able to separate those two groups because same reason that you identified, that we would be bound to the histologic assessment of varying pathologists nationwide.
Okay, thank you. Dr. Miller?
No, I agree with that. It all goes down to the pathologist, and especially when you're looking at people who have limited lung function and so forth, should you, do that lobe or, definitely do a segmentectomy on those smaller ones. But when you get up to those 3 and 4 centimeters, usually looking at a lobe on those patients and so forth. But it goes back to the pathologist and also goes back to the techs who are measuring those specimens. If they're 3.8 centimeters, 3.9, it makes a big difference in that patient's survival. So that's very important as we look into this in the future. It is related to size.
I'd like to take a minute just to congratulate you on an excellent fielding of questions and an excellent presentation. This is just a good example of how we're starting to answer important questions amongst these patients and how the STSA is playing a role in that. So thank you again.
Well, thanks for the opportunity, and I appreciate the questions and comments.
Okay. All right, great job.
Great. Thanks, everybody. There's a lot of people to thank. If I could have the presenters, the moderators, go ahead and get on the show your picture, that'd be great. We on the council and the executive committee for the Southern Thoracic didn't know how this was going to go, and I'm so proud to see how awesome that this has gone. I mean, it's beyond my wildest imaginations. We've all worried about how virtual Zoom webinars are going to go, and this is just, I think it's been absolutely spectacular. I've seen a lot of Zoom presentations when we haven't presented real research. We've presented just invited lectures. I think the way that this was done was just absolutely just very classy. The speakers were completely on point, and as were the moderators and the digital moderators. So I'm really just proud to be part of the Southern family that's allowing us to be able to share some of this original research with us. I want to remind the attendees to complete the webinar evaluation that you'll receive by email, and really specifically want to encourage all the Southern Thoracic members to attend the virtual STSA business meeting on Saturday, December the 12th at 9 a.m. One of the last things that I want to say is how proud I can say, not only for myself, but also the executive committee and also the entire council of 3 specific people who really drive 99.9% of the ship for the Southern Thoracic, and that's Beth, Laura, and Rachel. And so I'll take a moment at this point just to give everybody to clap on behalf of the 3 of them. So thank you. They're really the drivers for this. We just kind of show up and for me, I'm specifically watching Shanda to see how many times she changes her glasses during a webinar. Just like sometimes I watch the academies and I see how many times somebody's going to change their dress. As Shanda, I'm seeing how many times she's going to change her glasses. So I like
It's
that.
because
Maybe
he's trying to get the Ozer Abbott
I
Award
know,
being
I know
different
that he's
people.
creating a whole new thing.
Careful, guys.
So, oh my God, hold on. She's going to come back with a new set of glasses. There you go. See,
Oh, boy.
I knew that was going to be coming up. So, Jeff or Dan, Dan as the upcoming president, Jeff as the council chair. Any comments as we kind of close up for the last couple of minutes?
No, I think, we only picked the top 6 abstracts to present today, and I wish we would have done more. We didn't know how this was going to be, and hopefully this will never happen again. But I think, other meetings that we have and regional meetings and things that we'll be able to educate our colleagues. And I think this is a great avenue, and with the team doing that, I think everybody did a great job.
Yeah, Jeff?
Yeah, I again first like to echo your thanks to Beth and Laura and Rachel, who are the glue that hold us all together. And Vino, I'd like to congratulate you for your leadership. We're all very much looking forward to hear your presidential address 1 year from now, hopefully in the same room where we could then have some wine that evening. And with that, I guess we should wrap it up. And I'd like to thank all the attendees.
Yeah, thank you very much, everybody. Have a great day.
Thank you.